Good morning, everyone. Thank you for giving me this opportunity to meet you all this morning. So I'll be confining myself to pediatric retinal diseases, and some part of it will be oncology. So anybody can make a guess as to what this could be? Coats disease, yes. Looks like Coats disease, right? But then do an imaging. So what does it look like now? It's retinoblastoma, isn't it? So what we see here is calcium. So the Coats disease can mimic retinoblastoma and vice versa as well. So pediatric cases, like because of the difficulty in examining the child and because of the disease presents differently, it can stump us quite often. So how do you make it out? Is it Coats disease or is it retinoblastoma? So if we look at it carefully, clinically itself, we should be able to make it out. So retinoblastoma involves the retina. Coats disease does not involve the retina in the form of a mass lesion. The vasculature is there, but then all the exudates, the white stuff you see is under the retina in Coats disease. But if you see carefully, this looks like Coats disease, the total exudate with retinal detachment, retina is just behind the lens. But if you note carefully, see this white lesion is within the retina, is full thickness retina is involved. So when there is a full thickness retinal involvement, it's most likely to be retinoblastoma. So look for a mass lesion under the retina. So this will be an exophytic retinoblastoma. So that is the reason you've got an exudative retinal detachment. So look carefully for involvement of the retina. So this white stuff, this is the lesion which is involving the retina, full thickness retina. That will be a clue to make out that this is retinoblastoma indeed and not Coats disease. In contrast, here you see a total retinal detachment, but this yellow stuff is under the retina. It is not within the retina. So this may not be obvious on a photograph, but if you look at the child under general anesthesia, you should be able to make out this lesion is under the thing. And if you see, here the reflex is white, and here the reflex is yellow. It's pretty much obvious. So in my opinion and experience, what I have found is Coats to be the one where you cannot differentiate with retinoblastoma most often, and that's where the wrong diagnosis comes in. So these are all pictures of Coats disease. Not working. So you can see this one is we can simulate a macular retinoblastoma, but if you see the lesion is breaking up in the bits in the periphery, that would be an exudate suggestive of Coats disease. And again, this we already saw a total exudative retinal detachment with all the subretinal exudates underneath mimicking a mass lesion. But these are the classic cases. We will see these hard exudates, and due to a fluorescent angiogram, we can see these light bulb lesions. This is the clinical photograph of these light bulb lesions. To summarize the differences, retinoblastoma most often presents at birth or within the first 5 years. Coats disease, though the textbook says 10 years, that's not true. We have seen Coats disease as young as 6 months also. And again, it's not confined to boys. We have at least about 10 to 15 children in the last 2 years who are girls who present with Coats disease as young as 6 months also. And Coats is definitely unilateral. The retinoblastoma can be bilateral, and vitreous seeds may be present in retinoblastoma, but Coats disease does not involve the vitreous at all. Unless in extreme late stages where there is a vitreous hemorrhage, it does not involve the vitreous. Fundus reflex is white in retinoblastoma, yellow in Coats. Vascular malformation, as we saw on the first slide, may be present. A retinoblastoma may present like a Coats disease. In contrast, the Coats disease, the vascular malformation is the hallmark of the disease. We may not be able to see it. We have to give anesthesia and check the periphery, only then we may be able to see it. Mass can be intra, subretinal or vitreal, and the Coats disease mass, the so-called mass is actually a clump of exudates. So it can simulate a mass. That's it. It's subretinal Coats disease. Calcium is a hallmark in retinoblastoma, may be present in advanced case of Coats disease. And exudate with that RD is once again may be present in retinoblastoma. Coats disease once again it's a hallmark of the disease. So imaging, this is retinoblastoma, this is Coats disease. You can see no calcium and overall generalized haziness with a little bit of subretinal exudates, and there can be a plaque-like calcium in advanced cases where there is a sclerochoroidal calcification. And this is the ultrasound. You can see there is the choroid orbit is masked here because of the retinoblastoma calcium blocks the sound waves from going into the orbital area. So this is masked here. But here you can see an exudative retinal detachment with a lot of this tiny dot echoes in the subretinal space because of the subretinal exudate. So the treatment is different. Retinoblastoma may need an enucleation with a long optic nerve stump, but Coats can be managed conservatively. So this is just with laser photocoagulation. So this is how it goes. The child presented like this, multiple sessions of Coats with laser photocoagulation. This is the net result with a visual acuity of 618. So we can achieve this with other ways also. If it's a total exudative retinal detachment, you can drain the fluid, inject intravitreal. I prefer steroid because in my hands the anti-VEGF has not worked too well. We can inject and then attach the retina, do multiple sessions of laser photocoagulation to reach this result. So retinoblastoma can also mimic endophthalmitis. This is again can be disastrous if in case we don't image these patients and take them up for vitrectomy. Most often what happens is there is a trivial trauma. The child fell or a classmate hit the child, and then that is when the attention is drawn to the eye. The parents see the eye and then find something is wrong with the eye. That is how they present with. So we may find retinoblastoma in the anterior chamber in the form of an exudate or like a hypobion which doesn't shift. It's composed of large thicker cells. It doesn't shift easily. Or it can present like a endophthalmitis. So this is actually retinoblastoma which presents like a total vitreous opacity. But the clues are there. You can see the eye is quiet. An end of eye is never quiet. You will find CCC, a conjunctival condition. Nothing is there. So when you find a white reflex following a trivial trauma in an infant or a child, always we should do a imaging to make sure that we are not missing out a mass lesion before we do a vitreous biopsy. So it can present as neovascular glaucoma. What happens is when the retinoblastoma outgrows its blood supply, it tends to die. And when it dies, it sets up an inflammatory reaction. Or it can grow new blood vessels in the front part. It can be present with neovascular glaucoma. And when the tumor actually sets up the inflammatory reaction, it can become phtisical also. An unexplained phthisis in the absence of a trauma, we should rule out retinoblastoma in that type. It can present as mass lesions in the front part, and again it can present as orbital cellulitis. As I mentioned, when the tumor outgrows its blood supply, when it dies, it sets up an inflammatory reaction which can present as an orbital cellulitis. This is not orbital extension of a tumor, but just a reaction to the death of the tumor. So whenever we find an orbital cellulitis, once again we have to image the eye, and these eyelids may not be possible for us to open and see what's happening inside. So at least put an ultrasound to make sure we're not missing out the retinoblastoma. This settles down very well with just a course of oral steroids for about 3 to 5 days, and following which, like definitive treatment for retinoblastoma like enucleation or chemotherapy can be done. So this is a child with presented to us like this. So what do you think this is? Retinoblastoma? Whitish lesion. Child is about 5 years of age. But there is something different, isn't it? So the retinoblastoma, we see it to be a little vascular, whitish in color, calcium. But yeah, something looks very different. There's one more lesion here. So what we are looking at is astrocytoma. So this is another differential diagnosis of retinoblastoma presenting at about like 4 or 5 years of age. So when we look at the child in person, we can find this out. What we are looking at is adenoma sebaceum. This child has tuberous sclerosis. So when they present at such a younger age, usually they have tuberous sclerosis with these lesions in the eye. And astrocytoma usually is a small lesion in the periphery, or it can present like a mulberry lesion at the optic nerve head. So what is this? So this is again a very rare form of astrocytoma called giant astrocytoma. So this can present with an exudative retinal detachment. Usually astrocytomas do not need any treatment. They just have to be watched. They just have to ensure that it's not retinoblastoma. But very rarely it can be a giant astrocytoma presenting with exudative retinal detachment, extensive subretinal exudates. So this is again over the disc. So this is a very, very rare possibility or differential diagnosis, which is a giant astrocytoma. This responds usually well to photodynamic therapy. So what do you think this is? This is about a 10-year-old child with a pigmented lesion in the iris. Everyone awake? It looks like a melanoma, isn't it? Anybody would want to differ, saying it's not a melanoma? But then look at the color. It's blackish in color. Usually melanoma is brownish in color or slate gray in color. So it's blackish in color, and you see these pigment deposits on the surface of the iris. And what we're looking at is a melanocytoma. Melanocytoma does not mean that it has to occur over the optic nerve head. It can occur in the ciliary body and the iris. So what you're looking at is the ciliary body, the iridociliary melanocytoma, and this can be resected. Very easily it can be resected. And they present most often with the pigmentary glaucoma. And this is not a malignant tumor, though it keeps on throwing these pigmented cells in the anterior chamber causing secondary glaucoma. You can resect it very, very easily. This patient has undergone iridocyclectomy, saving the eye thereby. This is a different variant. This is a diffuse melanocytoma. So these patients will have heterochromia. So this part of the iris is darker in color, and there is a huge mass growing out of the ciliary body. And as you can see, the pigment studded over the iris completely. So this patient had a secondary glaucoma. So we did a biopsy to confirm it because we just needed to So this is a part of the steps is how we resect the tumor also. A trapdoor is created, a partial thickness scleral flap is created. So diathermy to decrease the risk of bleeding from the ciliary body. And then the inner wall of the sclera is dissected out. And you can see the color of the lesion. This is jet black in color. So usually melanocytoma is jet black in color. So this was taken as a biopsy to confirm. And then subsequently this patient had like usually melanocytomas can be resected, but this was extending for more than 6 to 7 clock hours. So we did brachytherapy. So we did a brachytherapy, and this is the regression of the tumor after brachytherapy. Usually it's not been described as a treatment modality. Usually they watch or enucleate the eye, but for the first time we did a brachytherapy, and this regressed after the brachytherapy. So this presents as a black pigmented ciliary body mass. It can be a solitary lesion as we saw, or a diffuse lesion. Presents with diffuse iris pigmentation, secondary pigmented glaucoma. It grows very slowly. It's not a malignant lesion, and usually present second to third decade, but it can present much earlier also. 10, 15 years also it can present. Melanoma is very, very rare in children. In Indian population, melanoma is rare, and in children it is rare. The youngest we have seen is 13 years of age. So, but then once again, as I mentioned, it looks brown in color or slate gray in color. Retinal child, this is about 6-year-old child presenting with a white reflex. So is it retinoblastoma? It is not, obviously not a cataract. The lesion is behind the lens, but something is different. Looks like a little bit of glial tissue also. So we did the ultrasound. It showed a posterior pole PRD. So there is no lesion in the posterior part of the fundus. And CT scan shows the lesion to be in the ciliary body region, with some kind of a traction detachment of the posterior pole, and the lesion is in the ciliary body. So what are we looking at? We're looking at medullary epithelioma. So this is again a cause of a mass lesion in a child, which actually is a mass lesion arising from the ciliary body. This usually presents in the pediatric age group. This is much rarer than a retinoblastoma, but also a differential diagnosis. Usually unilateral. It appears as a white mass arising from the ciliary body. It has a cystic component and a retronatal fibrous tissue component. Can present as an unexplained iris neovascularization. And mostly it is non-malignant, but most of the time we land up enucleating the eye because there can be malignant cell rest. So there is a very small possibility of saving this eye by resection. So this is one such patient with a cystic medullary epithelioma. This underwent resection. You can see this is a post-resection iridociliary resection. So you can see the rubeosis. These are slides which Dr. Jerry Shields gave it to me. And this is how we resect the tumor. This is a medullary epithelium of the ciliary body. What you see here is the retronatal fibrous tissue which is resected. So a lensectomy has been done. We are trying to decrease the size of the resection. So here we have already created a partial thickness lamellar scleral flap. So extending the dissection up to the ciliary body here. So that's a partial thickness scleral flap which has been created. The inside of the inner layer of the thinner sclera is being opened up amidst the diathermy burns. So this part of the lesion which is attached to the limbus is cut out. So the lesion is being resected. As you can see, this is the inner part of the sclera, the ciliary body with the mass lesion. The whitish lesion, this is the mass what you can see. This is the medullary epithelioma which is being dissected from the underlying vitreous. But as I mentioned, this may not be possible in all the lesions. Up to 3 clock hours we can resect it, and larger than that we may not be able to resect it. So that's the end of the surgery. So these again are slides which Dr. Jerry Shields said, because I have not seen this kind of typical medullary epitheliomas. More often a retronatal fibrous tissue is what we see. This kind of cystic component is something which we can see. So not all cysts are medullary epitheliomas. This is a patient who presented with seeing a blackish opacity floating around. The mother was worried. So what you see here is just a pigmented cyst. So free floating pigmented cyst. So differential diagnosis of this would be a cysticercus cyst, but as you can see this is pigmented, doesn't have a scolex inside, and has not set up an inflammatory reaction. A cysticercus sets up an inflammatory reaction when it dies, and it doesn't freely float like this. This freely was floating all over the place. So this is a patient who is about like 7 years of age, presented with retinal detachment. So anything looking different in this eye? Something is here, isn't it? Yes. Diffuse choroidal hemangioma can also present in a pediatric age group. it can present just like an exudative retinal detachment, and this lesion may not be very obvious. So unless we compare it with the other eye fundus. So there will be a very, very subtle orange coloration because there is not a bullously lifted mass. This is a very, very shallow mass lesion, a diffuse choroidal hemangioma associated with Sturgeon syndrome. The clue is in the lid or in the face. Look at them very carefully. We may see the angioma on the skin of the eyelid and the face, which may be there. So metastasis can also very, very rarely present. So not all mass lesions in children is retinoblastoma. So this was a child which underwent soft tissue sarcoma surgery when the child was of 6 years of age. The parents had actually forgotten about it. The child came to me when it was 14 years of age with a painful eye. So I found a huge mass lesion. It was referred as a melanoma. Melanoma is rare, but it can happen in 14 years of age. But the lesion was not looking like a melanoma. It was not pigmented. So when I dug back and asked for the history, they said like the child underwent a sarcoma surgery when the child was 6 years of age. So this was metastasis presenting 10 years later, and child subsequently died. So this is something which may present rarely. Any differential diagnosis? Presenting with macular edema? Anything? Here, the clue is here. Follow these. Where do you go? Go to a peripheral retinal angioma. So it can just present like a macular edema. But the problem is in the periphery. It just presents as a macular edema. Go to the periphery, you will see the retinal angioma, von Hippel-Lindau disease. So this is post-treatment. So this is what happens after treatment. You can see the lesion is, the macular edema is gone, the lesion is regressing. So yet another patient presenting as macular edema. Dr. Shukla did show what it was. Very, very classic. Yes, nasal part of the retina showing retinoschisis-like appearance. Yes, an optic disc pit. So this can also present just like a macular edema. We have to look at the optic disc much more carefully to diagnose this. Yet another patient presenting with what appears like bilateral central serous retinopathy. Is it bilateral central serous retinopathy? Central serous retinopathy in children we hardly see, isn't it? So what do we look for? The clue is here. See this yellow stuff? So what is it? Dr. Shukla again showed, yes, Best disease. This is actually just before the atrophic stage, after the vitreal eruptive stage. The yellow stuff would have gone. This is when it's very, very difficult to diagnose what it is. So do a autofluorescence. Beautiful pictures you can get corresponding to the lipofuscin accumulation. So autofluorescence or an OCT will tell us what the diagnosis even before we do an EOG. So Stargardt's disease can present like this. It can present like a macular scar, but not all macular scar is Stargardt disease. The children can present like this also, what appears like a macular scar, but usually it's unilateral. So what you're looking at is toxoplasmosis. It can present as a macular scar, but usually unilateral. So this is another child, 12 years of age, presenting with a lot of inflammation and a mass lesion. So any differential diagnosis? This can present like an endophthalmitis. We can think of it as a retinoblastoma, but then the inflammation doesn't look like vitreous cells. A yellow mass lesion is here. So what you're looking at is toxocariasis. So this can also present as a white reflex and can present unilaterally. And we should ask for history of having pups at home. And we can do a surgery in these patients and regain some vision in them. So these toxocariasis can sometimes result in a falciform fold. So not all falciform fold is toxocara. It can present an FEVR, like Dr. Ananja had mentioned earlier, with the dragging of the disc. And like the FEVR can present as an ectopic macula. In the absence of history of prematurity, we should think of FEVR and look at the periphery very, very much more carefully. Other differential diagnosis being the extinct retinoschisis. So FEVR is usually an autosomal dominant disease and appears as peripheral neovascularization and can present as a temporal dragging and a falciform fold. And it can result in retinal detachment and lipid exudations bilateral. But the thing is, like, the disease can be of so varied manifestation amidst the family members. They can be totally asymptomatic in one person, but you examine the fundus and find these lesions. But some of them can be particularly blind. And lastly, the white reflex can be because of ROP. So, of course, the history is the clue here. Ask them for a history of prematurity. Then, of course, we find this to be a retrolental fibrous tissue. So, retrolental fibrous tissue need not always mean ROP. It can be FEVR. It can also be, as I mentioned, a medullopithelium also. So, that brings me to the last slide. So, this is the last thing. So, if there are any questions, I'll be happy to answer.